Okay, okay, fine. Yeah, start now. You can start now.
Yes, good morning, everyone. Today's topic is
We can't hear you, Aishwarya.
coming to introduction, surgery, surgical correction of error.
We can't hear you.
In
I
the
think we can't hear you. I think some problem with the internet there. Hello, hello.
now, am I audible?
Yeah, better.
Yes.
Okay, you can start now.
Yes. So the purpose of refractive surgery pre-op evaluation is to determine if the patient is a suitable candidate for refractive surgery or not. Refractive surgery, being an elective cosmetic surgery, must be of low risk with a significant improvement in vision. Hence, a careful pre-op examination of the patient is of utmost important. In evaluation, history taking, clinical examination of the eye, and investigations are done. Coming to the history taking, age of the patient is important because such surgeries are recommended usually after 21 years of age, and any history of previous usage of glass to know is important, because to know the stability of the refraction, and any contact lens usage, especially if it is soft lens usage or a rigid contact lens, because contact lens will alter the contour of the cornea, and also and also to know the patient's expectations. Coming to ocular history, any known case of herpetic eye infections, because it might reoccur, any history of constant eye rubbing, any prior refractive surgeries, any squint surgeries, and the use of lubricants should be asked, because this will mask the dry eye, which is the most common complications post refractive surgery. In systemic diseases, we need to ask if the patient is a known case of diabetes or autoimmune diseases, collagen vascular diseases, because these are the relative contraindications and they might alter in wound healing. Pregnancy and lactations are also contraindicated, and any hormonal therapy, especially in PCOD patients, should be ruled out. Coming to drug history, especially in migraine and acne patients who are on isotretinoin and antihistamines, these drugs cause dry eye. So these drugs should be stopped at least few weeks before the refractive surgeries. Social history, the profession of the patient matters, because in contact sports like boxing or karate, in such patients, trauma, they are high risk for a trauma, and flap related surgeries like LASIK are usually contraindicated. History of alcohol, cigarette should also be asked. Coming to clinical examination, visual acuity is tested mainly with either Snellen chart or Logmar chart. Both uncorrected visual acuity, best corrected visual acuity, along with near vision is documented. And coming to refraction, good dry refraction is done, and also cycloplegic refraction is done using with either tropicamide or homatropine. Homatropine can be used in a patient with hyperopes to relieve accommodation. And then lensometry is done to check the stability of the previous refraction. Specular microscopy is done to see the endothelial cell count. Intraocular pressure can be documented, and also near point of convergence is important, because in patients with myopia, these patients have convergence insufficiency. So to rule out that, pre-op near point of convergence is tested. If there is convergence insufficiency, then priorly we need to advise some exercises prior to the surgeries. Then coming to external eye examination, lid position is checked to rule out any ptosis. Position of the eye, such as any tropias, and cover test to see to look for phorias are done. Ocular motility should be examined, and in orbit anatomy, deep set eyes and narrow palpebral fissures are ruled out, because in narrow palpebral fissures, suction losses will be there, and in such cases, LASIK is usually avoided. Then coming to pupil examination before dilatation is important. To see any reaction to the light, if there is any anisocoria or a PD. Size of the pupil is important, because if the size of the pupil is more than 5 mm, post-refractive surgery, patient will have glare halos. So it should be advised prior to the patient. Coming to slit lamp examination, tear film analysis, especially its height and all, is done. Lid margin is examined to rule out any blepharitis and all. Conjunctiva is assessed for papillae. Cornea is assessed for any scars, vascularization, thick peripheral corneal nerves, fissure ring, especially in keratoconus, and anterior chamber depth using Van Herrick's grading is documented. Then a lens is seen for any nuclear changes, nuclear sclerosis changes or not. Then complete 90-day examination as well as dilated fundus examination is done, especially because in high myopic patients, there will be a risk of pathological myopia, degenerative changes. There is any lattice or break, prior laser is important in such cases. Then coming to dry eye workup, Shermer test, tear breakup time, tear osmolarity, and mebography, if available, is also done. Coming to investigations, most important investigation is corneal topography, which is the most important screening test for refractive surgery to detect abnormalities, to diagnose any early cases of ectatic corneal diseases, to diagnose post-kerato refractive ectasia, and put the plan for the best choice in refractive surgery. It involves a 4-quad map and a Belin embryo enhanced ectasia display. So this is the sagittal map, which tells the characteristic features of the anterior surface of the cornea. So there are various patterns seen in the sagittal map, which is a round, oval, superior steep, inferior steep, irregular pattern, symmetrical bow tie with skewed radial axis, a symmetrical bow tie with inferior steepening, a symmetrical bow tie with superior steepening pattern, and this is a symmetric bow tie with skewed radial axis, butterfly pattern, claw pattern, and junctional pattern. So this is a symmetrical bow tie pattern with the rule astigmatism. This map shows the symmetrical bow tie against the rule astigmatism. This is the superior steepened pattern. This is the inferior steepened pattern. And this is symmetrical bow tie with the skewed radial axis. And this is a symmetrical bow tie with inferior steepening. This is a symmetrical bow tie with skewed radial axis. And this is butterfly pattern and crab claw pattern, which is commonly seen in pellucid marginal degeneration. And coming to anterior and posterior elevation map, the most common normal shape is the hourglass pattern. Abnormal shapes include irregular tongue-like extensions. And in pachymetry map, it measures the thickness of the cornea at all the points depending on the elevation map. Difference between front and back surface elevations indicate corneal thickness. Minimal residual stromal bed for LASIK should be at least 300 microns. If a CCT is less than 500, then it will be a risk factor. A normal pattern seen in the pachymetry map is concentric. Abnormal patterns include dome-shaped, horizontal displacement, and bell-shaped. This is the abnormal shape. This is horizontally displaced map, and this is bell-shaped map seen in pellucid marginal degeneration. Then coming to corneal topography screening parameters, which suggests there is a risk in the cornea. In a sagittal map, if the Kmax, maximum keratometry reading, if it is more than 48 diopter, if the skewed radial axis is more than 22 degree, if inferior superior difference is more than 1.5 diopter, then the cornea is at risk. And in anterior elevation map, if it is more than 12 mm, posterior elevation map, if it is more than 16 mm, in pachymetry map, superior inferior difference, if it is more than 30 mm, CCT is less than 470 mm with normal topography. If CCT is less than 500 mm with abnormal topography, indicates the cornea is at risk and need to be screened. And based on a Belin or Ambrosio enhanced ectasia display on the difference map, if the front elevation is more than 5 mm and back elevation, if it is more than 12 mm, it also indicates the cornea is at risk.
It's not 12 mm, it's 12 micron and 5
Yes.
micron.
Yes, sir. Coming to a refractive surgery classification, it is cornea-based and lens-based. In cornea-based, in incisional based, there are various surgeries like radial keratectomy, limbal relaxing incision, corneal ring segments. Laser-based surgeries are PRK, LASIK, SMILE, and also LASIK. In lens-based surgeries, there are surgeries like phakic IOL and refractive lens exchange. Laser-based refractive surgeries are surface ablation surgeries like PRK and LASIK, which uses excimer laser only. Femtosecond LASIK, it uses both femtosecond laser as well as excimer laser. Smile surgery, it uses only femtosecond laser. Coming to the refractive correction, which is of FDA approved, surface ablation and LASIK surgeries can be done to correct can be done in spherical errors with -10 to +4 diopter, with cylindrical error less than 4 diopter, while smile surgeries can be done in -1 to -10 diopter spherical error, and to correct -0.75 to -3 diopter cylindrical error. While phakic IOLs, both hyperopia and myopia +3 to -20 D with less than 6 diopter can be corrected using phakic IOLs. Who is the ideal candidate to undergo refractive surgery? Any patient whose age is more than 21-year-old, who has a stable refractive error since more than 1 year, who is not pregnant and non-lactating woman, and no any systemic or autoimmune diseases. Coming to contraindications, in ocular contraindications, any unstable refraction, severe dry eye patients, progressive corneal ectasia, recurrent uveitis, herpetic disease, large pupil size, which is more than 5 mm, and glaucoma patients are contraindicated. In systemic pregnancy, lactating, systemic autoimmune diseases are these patients are contraindicated. Drugs, systemic corticosteroids, amiodarones, somatriptan, antihistamine, isotretinoin. These patients are relatively contraindicated. Few drugs can be stopped few weeks before the surgeries and then can also undergo surgery. Coming to cutoff parameters in LASIK or SMILE, the residual stromal bed thickness, the formula is a CCT, central corner thickness, minus flap thickness, minus depth of the ablation, should be at least 300 microns. Percentage of tissue altered, which is formula is flap thickness plus depth of ablation divided by central corner thickness, should be minimum 40 to 50%. Cutoff parameters for phakic IOL. Anterior chamber depth should be more than 2 mm and less than 4 mm. Wide to wide should be more than 10.8 and less than 13. And to rule out any lenticular opacities. So, refractive surgery options in cornea-based procedures. If residual stromal bed thickness, if it is more than 280 mm, and percentage of tissue alter if it is less than 40%, these patients can be taken for cornea-based surgeries. If residual stromal bed thickness it is less than 280 and percentage tissue altered if it is more than 40%, these patients can be taken for lens-based procedures. So in a PRK, high refractive error, thin cornea, low refractive error, and predisposed to trauma. Such candidates are suitable for PRK. Low, moderate, high myopia, such patients can be taken for LASIK. Low, moderate to high myopia, patients involved in contact sports and mild dry eye, such patients can be taken for SMILE surgeries. Phakic IOL, if a patient is less than 40-year-old, if there is crystalline clear lens, they can be taken for phakic IOL. And any early cataract changes, age more than 40-year-old, they can be taken for refractive lens exchanges. So the ideal candidate for refractive lens exchange would be hyperope and with presbyopia. Thank you, sir.
Okay, go to the slide of presbyopic lens exchange. Yes. So, what is you have written only this?
Yes, sir.
No other thing. Now, in next few years, basically, the numbers of refractive lens exchange are going to increase, like what has happened in other countries, in developed countries, because after 40s, many patients want to get rid of the near glasses, and particularly those who already had distant glasses, they want to get rid of this. And it has been proven now that presbyopic lens exchange actually has the same kind of safety that cataract surgeries have. And that's why. So, what are the IOL choices when patient comes for refractive lens exchange? Hello.
Hello, sir.
Yes. Answer. Okay.
50 to 75,000.
What? Not price. What are the choices of lenses? Which type of lenses you will use?
So
Amok.
multifocal.
Yeah. Amok, come to near the laptop. You can answer.
So can you repeat the question?
When patient comes, say patient is 45-year-old and patient doesn't want to use specs. Okay. So in
Yes.
that situation, how do you determine what refractive surgery you are going to do? If you are going to do corneal refractive procedure, then which type of corneal refractive procedure? If lens-based procedure, then which type of lens-based procedure?
But first, we will judge the refractive error. If he is a high myope or high hyperope, and we will determine the corneal parameters on pentacam. If cornea is fine, then we'll go for a lenticular procedure like clear lens exchange. And
If cornea is fine, then you will go for lenticular exchange. I didn't get it. You mean to say cornea is fine for doing refractive surgery or cornea is just fine?
I
See,
mean to
for
say,
every situation, you should have a mental flow chart. Okay.
okay.
Okay, fine. Cornea is fine for what?
Cornea, I mean, there is no any ectopia or something like that. So,
Ectopia.
I mean to say,
45-year-old patient comes to you, wants to get rid of glasses. Okay. So what is the flow chart that you are going to follow?
first we'll look for his requirement of vision, like what is his profession, whether he has a driving, he wants to drive or anything like that. Then
Okay.
accordingly, we can judge.
Next. Okay, Namrata, you are there online?
Yes, sir.
Yeah. Can you tell me what is the flow chart for this patient?
So we will first assess the amount of the grade of myopia he has and hypermetropia. Accordingly, after pentagram, if cornea is normal and patient is not having any risk, it's not an early family, it's not having risk of any trauma, we can go for a flat face or procedure. Otherwise, we consider PRP for reflection. And So we cannot do anything to qualify.
Your voice is not. Your voice is not
So I'm
very clear.
traveling actually. So I'm traveling.
Okay, no problem. Okay, we will ask somebody else. So, in the doctor's room, who else is there?
Around the dishes.
Yeah, Shishir, please go ahead with the.
Sir, in
Okay. I will.
40,
I
45.
will. I will write down different situations. Okay, you can see it, na?
Yes, sir.
Okay. So let's go ahead with 45-year-old female patient, no driving. Okay, +2 for distance. Okay, and +1 addition. Okay, tell me. Hello.
Sir, sir, since the refractive error is small, sir, I would like to go for cornea-based procedure, sir. But I have to rule out whether there is any early cataract or not. So if the lens is clear, then I would like to go for refractive-based procedures.
You mean corneal procedures?
Cornea,
Okay.
yes, sir, yes, sir, cornea.
Which
Because
procedure?
Can go for hyperopic LASIK.
Anything else? You will take care of only distance, or you want to take care of near also?
Press beyond.
Okay. So if the patient, there is a cross blur test to check whether patient accepts monovision.
Yeah.
So if the
Yes.
patient is accepting that, then we go for press beyond in this patient. Okay.
Oh.
If
Okay.
not accepting, then we can go ahead with femtolasic or LASIK, or maybe trans-PRK based on the corneal this thing. Okay. Only if you can't do press beyond, only issue is that patient will need glasses for near.
Okay.
Okay. Any other option? Second option is using phakic IL. So we can use presbyopic IPCL. Okay. If the AC depth is adequate for putting IPCL, we can use IPCL presbyopic, which has again multifocal rings in that. So that will take care of distance as well as for the near.
Yes.
Okay. Only this thing in IPCL is that over a period of time, because already patient is 45-year-old, patient is going to need cataract surgery later, maybe 5-10 years down the line.
Yes.
Okay.
Yes.
And third option, which is also a very good option in this patient is clear lens extraction. Okay.
Yes.
So in
Yes.
clear lens extraction, patient can go ahead with trifocal or EDOF based on the requirements. Okay.
Okay.
And of course, here the potential vision is important. So in all cases which I'm going to tell now are having potential vision of 6/6. Okay. Without any
Yes.
retinal or other pathology.
Yes.
Okay. Now, same thing. Let's see, say patient has -2 and addition. Then any change in choices? Yes or no?
No.
Okay, not much change. Okay, almost same. Okay, but
Yes,
now
sir.
let's see. Patient has say +5 for distance with addition. Now, what is preferred choice?
First, we can go for clear lens exchange.
Okay, so we can go for CLE or IPCL, but most often what happens when you have such hypermetropia, the ACD is usually on shallower side in these patients. Very rarely you have adequate AC depth. Okay, so
Yes.
generally in those cases, CLE is what is preferred.
Yes.
Okay.
Sir, I had a doubt. When to do hyperopic LASIK? Is it indicated in such patient?
So hyperopic LASIK is generally done up to +4, not more than that generally. Okay. And the problem with hyperopic LASIK is that the chances of regression are high.
Oh.
So generally, we do it in younger patients and those who want to get rid of glasses for some job or other activities. But the chances of regression, we have to explain to the patient because there might need a retreatment after few years. Okay. But for older patients, I would avoid hyperopic LASIK. I would rather go for a lens-based procedure. And lens-based procedure will have long-term stable results as compared to LASIK in that.
Yes, sir.
Okay. As the age increases, for example, this is 55, then obviously we don't generally consider corneal refractive procedure. We generally consider lens-based, that is CLE only.
Yes.
Okay. So as far as the
Yes, sir.
lens choice is concerned, okay, for example, it depends on, as Aishwarya said, the requirements. So if night driving is one of the requirement and patient was refractive correction also, we go for EDOF. Okay.
EDOF.
Yeah. So EDOF, it is not so that it will not absolutely have no halos or glares. Generally, glares are not there with EDOF because there are no sharp edges. Okay.
Yes.
But minimal halos will be
Yes.
there in EDOFs. Okay. And most of the patient tolerate those halos. The advantage is that near work, they can do most of the near work without any glasses. Okay. Now trifocal, there will be some glares, some halos. Okay. Near vision is better, slightly better, particularly not near vision. What I mean is that at closer distance, the vision is better. Okay. So EDOF generally gives good vision 50 centimeter and more. Trifocal 30 to 50 centimeter also, patient may have fairly good vision. Okay.
Yeah.
In some patients, those who absolutely do not want any halos and but don't mind wearing specs sometimes, we can go for advanced monofocals. Okay. Now advanced monofocals basically are monofocals only, but use of spherical aberrations. What they have done is they have added around +1 diopter of add. Okay. So this patient may have better intermediate vision as compared to standard monofocal. Okay. So sometimes we can also do monovision, like suppose one eye targeting emetropia and the other eye we may target -0.2 to -1.5 depending on what you want to give myopia. And in that case also patient may have fairly good near vision or intermediate vision with monofocals.
Yes.
Okay. Whenever you are doing CLE, we have to make sure that retina is okay, and also we have to look at the astigmatism very carefully. Okay. Because most common residual errors after doing cataract are astigmatic errors. Now the spherical errors have reduced significantly because of the optical biometers that we use. But astigmatic errors can occur because of pre-operative astigmatism, existing astigmatism, or can be induced by the surgical induced astigmatism. So we have to be carefully watching for the astigmatic correction. Okay.
Yes.
Yes, sir.
Okay. Any other questions? Yeah, any other questions?
Sir, in terms of intermediate vision, which lens is better, trifocal or advanced monofocal?
In terms of
Intermediate vision,
intermediate vision, which is better?
which is better, trifocal or advanced monofocal? Because both have.
Yeah. So basically, advanced monofocal doesn't have plus 1.5 add. Okay. It has somewhere around, some lenses of 0.6, 0.7 add, some have plus 1 to 1.2 add, but not 1.5 add. So advanced monofocal will have decent intermediate vision, but the reading quality will not be as good as trifocal or EDOF. Okay. So EDOF will have much better intermediate vision as compared to advanced monofocal. Okay.
Yes.
Any other question? Hello.
Hello, sir.
Yeah.
Sir, like post cataract surgery, if residual refractive error is high, means so we have to do that lens exchange, or we can implant one more lens in the sulcus.
Yeah. So
If we think that the capsular fibrosis and all is there.
yeah. So post cataract for residual error, we have few choices. If the error is quite large and the surgery is done recently, then we can do exchange. Okay. If the error is very minimal, say 0.75 cylinder or 0.75 spherical, something like that, then we can just do corneal procedures like femtolasic, smile, or we can do trans-PRK. Okay, if the cornea allows for the corneal procedures. Or the option is of sulcofix or sulcus IOLs, which can take care of the residual spherical as well as cylindrical errors.
Yes.
Okay.
Sir, recently means up to 2 or 3 months, sir. Or
Recently operated?
means the time period is up to 3 months or 6 months.
Yeah, so it depends on lens to lens. Some of the hydrophilic lenses, they don't get stuck, they don't stick to the capsule.
Yes.
So in that case, even after 2-3 months also we can try to remove. The major issue in that is fibrosis around the haptics. The optic itself is not sticking to the capsule. For hydrophobics, generally first month is easier. After that, it becomes little bit difficult.
Okay.
Okay. So earlier the better, but of course, for first 1 month, we generally don't do exchange unless it is evident that there might be huge refractive surprise because of maybe calculation error or axial length error. In that case, so we can immediately, like in next day also, or within a week also, we get to know that the IL power is wrong, so we can exchange immediately. But those patients who are having difficulty in adjustments, like for example trifocal or EDOF patients, maybe if they are seeing, which is very rare, if they are not tolerating the lens or something like that, then it can be we generally wait for a month, because many patients get adapted to the these multifocals or trifocals or EDOF. So after a month we can try to do the exchange.
So after 2 or 3 months, if the error is very high, then it is the choice of surgery is to implant another IOL only.
Yeah,
Like
that is easier.
in the sulcus.
Yeah, if it is only refractive surprise or refractive error, then using a sulcus IOL is easier and better option. But if it is intolerance to the lens, then IOL exchange has to be done.
Okay.
Okay. Okay, we end then.
Yes, sir.
Yeah. So you must have seen in OPDs also, and we do get inquiries about post presbyopia refractive correction. So in that, in those patients, suitable patients, we can advise clear lens extraction, because many patients they want to get rid of glasses, or many are not even using specs. Okay, so in those
Yes.
patients we can advise, and now a lot of options for treating is available.
Yes.
Okay.
Yeah.
Okay, we'll end the meeting.